Well, thank you very much, Derek, and thank you very much, Roy and Klaveness, for your invitation. I've got a remit of speaking before coffee and after coffee. It may be quite a long time, so if you want to interrupt as we go along, it's a nice sort of friendly small group, as it were. Please do. My wife has sympathy listening for you listening to me for all that length of time. So, as Duncan has said, we have a problem, amputation every 30 seconds. Throughout the UK, there are 30 amputations per week, and most of these amputations are preventable. I think my remit leading up to the main talks on pressure and mechanical aspects is to paint the picture of the diabetic foot patient so that you have got a full understanding, a better sort of feel for that patient as you see them in your consulting suite, whether you're looking after their shoes or their feet as such. And my theme really is one word, and that's vulnerability, a vulnerable patient. And three pathologies lead to that vulnerability: neuropathy, ischemia, and infection. And neuropathy and the complications of neuropathy I will deal with before coffee, and infection and ischemia after coffee. So that's the plan. Diabetic neuropathy, the most common cause of neuropathy in the developed world. 60% to 70% of people with diabetes will have that form of nerve damage, stocking distribution, leading to numbness and susceptibility. And the nervous system is really one of the great pinnacles of evolution, or creation, depending how you look at it, as it were, in a sense that we have a system which is alerting us microsecond by microsecond as to what's attacking us from outside and what's going wrong inside. And if a patient has a damaged system, they become very, very vulnerable. And that's sort of a picture of the whole nervous system, the different nerves. And one has to say that nerve damage leads to a devastating disability. In some cases, very early on, and you will have seen these, it can lead to very disagreeable pain when the nerves are being, as it were, irritated by the high sugar. You can get this painful, horrible, painful neuropathy. But the most burdensome aspect really is the numbness, the reduction in sensation, which leads to the diabetic foot. Because the nervous system controls the internal system as well as protecting from outside, the body's homeostatic reflexes are damaged, and so it's a life-threatening complication. And one clinic in London looked back after 30 years at the parameters that predicted the worst outcome in patients. And you would have thought it might have been blood pressure, you might have been thought it was cholesterol, but it was the loss of the ankle jerks, a sign of neuropathy, which predicted the most accurately. So it's a very important complication. And why? The peripheral nervous system is an early warning system. It detects external insults to the body and the internal malfunctions within, and it's programmed through the brain, as it were, to direct appropriate protective responses and to maintain, as it were, the homeostasis, that's sort of the equal environment, integrity of the body. And it's damaged in diabetes. And in some diabetic patients, it's very much damaged. And that's why, to a certain extent, we have to have the system that Duncan's put in. We have to be the protection, and we have to do the screening. So, as well as the nerves going to the feet and to the leg, there are nerves, as it were, going to the rest of the body. So you also get what we call an autonomic neuropathy. That's the nerves to the autonomic organs. So your patient with an ulcer, you may be fitting shoes on, may have neuropathy elsewhere. And these produce various different parameters. The control of breathing may be affected. The control of blood pressure. So when the patient stands up, he drops his blood pressure, postural hypotension. The stomach may be disturbed. So the patient has gastroparesis, paralysis of the stomach, diabetic diarrhea, a neuropathic bladder, doesn't feel the bladder filling up, erectile failure, edema, and Charcot arthropathy, which I'll come to, and also some very subclinical abnormalities. So the whole body may be affected by this neuropathy. So you're dealing with a very vulnerable, susceptible patient. They may be subjected to trauma and they have no awareness. They may have infection and no tenderness or fever. They may have gangrene and no pain. They may have a heart attack and no pain because the nerves to the heart are gone. So you can be treating a patient and they may look really very grey and sweaty, and you ask them, do you have any pain? You say no. Oh, you say, can't be having a heart attack. But they may well be having silent ischemia. And if their blood sugar goes low, they have no warnings often. So this is, the picture of vulnerability. And I like to think of it in a colloquial sense, in the sense that in our West End in London, we have the musicals, and there's the one musical which says, love changes everything, the way you live and you die. Willie will sing that this evening if you ask him, actually. I won't trouble you in seeing you. But I like to think that neuropathy changes everything. So the signs and symptoms of these insults are diminished, the internal malfunction is not sensed, and the problem is diagnosis may be delayed, and the window of opportunity is missed. But although we don't pick it up, it's still going on. It's still going on. And then the end stage of tissue death is quickly reached. So we've got to have all these systems on board. So that's one big vulnerability, the neuropathy. But the poor diabetic patient has other vulnerabilities, particularly the immune system, which is our sixth sense. So we have an immune system which recognizes bacteria and viruses and tumor cells and gets rid of them. But it works partly by producing inflammation, which is recognized by the nervous system. And this circuit, as it were, is disturbed in diabetes, partly because the immune system itself is diminished, and partly because the nervous system, we've just heard, is also diminished. So in diabetes, the immune system and the peripheral nervous system are deficient, and the body is unaware of bacterial invasion. So the bacteria gets into the body. We see it into the feet, of course, but it also in other organs. And sometimes I think back and wonder, in response to what Duncan said, what have I been doing over these last 30 years? In that sense, apart from making all that coffee, as it were. And I think mainly what I've been doing is actually diagnosing and treating as early as possible episodes of infection in these patients. And we see this, and I'm sure you see it, as the older the patient gets, the more immune deficient he gets. So we have some patients who are virtually having infections consecutively with only a few days, sometimes weeks between infections. So that's another problem. Now, as if that's not enough, you've got neuropathy and infection, and then there is ischemia. And microvascular complications per se can cause neuropathy, so I've linked it like this. So neuropathy is a microvascular complication, retinopathy, so the poor patient cannot feel his feet, may not be able to see his feet. And then they also may develop nephropathy, and the feet become swollen and edematous. So that is a three-pronged attack on the microvascular complications. And then, with increasing age, they have macrovascular complications. They get ischemic heart disease, cerebrovascular disease, and, as we know, peripheral vascular disease in our diabetic patients. So the neuropathy, the infection, and the ischemia leads to a greatly vulnerable patient. And as Duncan has alluded, the 5-year mortality rate is significantly high in our patients, whether you have a neuropathic ulcer or an ischemic ulcer. The mortalities are up there, with greater than breast cancer, prostate, Hodgkin's, and basically the same as colon cancer. So just to highlight this, when a diabetic patient develops nerve damage and arterial narrowing, he becomes vulnerable to ulceration and gangrene. And one's got to set in system a multidisciplinary service with instant access and provision for long-term follow-up. So how do we approach this problem? How do we look after these very vulnerable patients? Well, one approach can be initially classifying what we're dealing with, understanding the natural history, and then coordinating the multidisciplinary treatment. There are several themes which work through, I'm sure, you this morning and this afternoon, so forgive us if we repeat it, but I think it's a case of just being very clear on these. There is the neuropathic foot and the neuroischemic foot, the classical neuropathic ulcer on the plantar surface and the ischemic ulcer on the margin of the foot, both of which do need mechanical relief. And the neuropathic ulcer has received a lot of attention over the years, but now with the increasing number of neuroischemic patients, we also need an approach, a consensual approach to relieving pressure and mechanical aspects on these. And in a way, that's not quite so difficult because it's not the plantar aspect, it's more the marginal aspect which needs now to be protected and protected early on. So this is the natural history as regards ulceration as we see it. We start off with the high-risk foot, which Duncan's system is basically picking up, screening for the neuropathic foot with the autonomic neuropathy, the dilated veins, and the motor neuropathy with the deformed toes, and we've got the neuroischemic foot neuropathy and ischemia. You can see the edema there from the cardiovascular disease, and the deformity not related to diabetes, or hallux valgus, but you can see there pressure from a tight-fitting shoe because of the edema, and that edema should be treated, and that patient should be in a wide-fitting shoe, and we should, with our screening and with our assessment, as Duncan has described, we should be able to prevent ulcers. But in many cases, at the moment, we can't. So we have the ulcer on the neuropathic side, on the marginal side, but it just doesn't stop there with diabetes. It is now a portal of entry for infection, and we get signs of infection in the later stages, which we can recognize, the cellulitis and erythema. And to repeat myself again, it doesn't stop there. The infection goes to gangrene, the wet gangrene of diabetes. and that's the gangrene, the necrosis, both in the neuropathic foot and the neuroischemic foot. So in the neuroischemic foot, the gangrene, in fact, has got two drivers. One, the infection, and two, the reduction in blood supply. And that's the natural history which has defeated every healthcare system in the world. There's no healthcare system that really can cope with this. Scotland is having a real great go at it, and we look forward to their results. But we've just got to think of ways of dealing with it. And of course, the protection at this level is everything. If we could really prevent these ulcers, then everything that follows would also be prevented. But at the moment, we are not. And we've got to reverse this natural history with the multidisciplinary management, dealing with the wound, the mechanical aspects, which will be the main theme of this conference, the vascular aspects, the microbiological, the metabolic, and the educational, as Duncan has alluded to. So that is sort of, in a sense, coming to the end of my sort of introduction. The diabetic foot patient is very vulnerable. The natural history is rapidly progressive and can be complex. He or she requires care that is easily available, specialized, coordinated, both in the short term and the long term. And how do we do this? Well, I think one has to have a screening system, an assessment system, and a foot clinic, a multidisciplinary foot clinic, which acts as an admission center, easy access, emergency service, direct hospital admission, follow up these patients, as Duncan says, don't lose them, hospital discharges, ulcers, post-op wounds, amputations, and an operation center for both the hospital and the community. And that's what I think in the bigger hospitals, subserving a district, as it were, one has got to have these. We have to have these operation centres, and I like to think we work at one in King's College Hospital, and we are busy from 9 to 6 or 8 to 6, Monday to Friday, and it's increasing and increasing and increasing at the moment. Within the hospital, we are coordinating the work within the hospital with the haematology, microtransport, imaging, physio, pharmacy, ward, vascular, biochemistry, but also within the community, the patient with the GP, the community nurse, the community podiatrist, the residential home, the social worker, and the relative carer. So we've got this very vulnerable patient with this great susceptibility, and somebody has to be father and mother to them. Because by the time they're really into trouble, they're in their 60s and their 70s and their 80s. And they're a very vulnerable patient. Because, and we looked at our patients, the 70 and 80-year-olds, they left school at probably about the age of 14. And they don't really have a lot of insight into, they don't have a lot of education, and they need a lot of looking after. And this is a sort of a picture of our sort of open access clinic, taken a little while ago now. Now in Britain we're not allowed to wear white coats, so that's a little out of date. So that's the multidisciplinary team, the podiatrist, the nurse, the orthotist, surgeon, and the diabetologist. Not put in any order of preference, of course, as it were. So just a few words. So forgive me for sort of concentrating on this background, but I think it's very important that you have this sort of feel for your diabetic patient. So with neuropathy, diagnosis, main problem is the neuropathic ulcer and the Charcot Foot. So the neuropathy can be diagnosed quite well with a sensory examination, monofilaments, vibration threshold, a thermal threshold. So you can simply measure it by detecting this sort of stocking loss using just cotton wool, and just, as it were, asking the patient whether they can feel the cotton wool as you go up the foot and leg, and detecting, as it were, a level where the sensation becomes normal. If you want to be more specific, As Duncan's implied, you can use the monofilaments. These are of varying diameters. Basically, they're applied perpendicularly, and they extend a standard load on buckling at 90 degrees. And this is the 10-gram filament. Patient cannot feel that. And as you can see, it's a patient who has been in trouble and has already lost two toes. I mean, this patient's at risk anyway, so you wouldn't really do the filament on this one, but we would just diagnose. This is indicating the value of the filament. Those who cannot detect a monofilament on one or more areas of selected site, 10 times more likely to ulcerate than those who can detect it. So that was a prospective study in 1992. You can use a neuroanesthesiometer to detect quantitatively a vibratory stimulus. Greater than 25 volts is important. So a vibration perception threshold greater than 25 is associated with ulceration. In cross-sectional studies and in a prospective study, a VPT of 75 greater than 25 volts was associated with a 7-fold risk of ulceration. One of the problems with neuropathy is the nerve damage is that we have large fibers which have myelin and small fibers which don't have myelin, and the large fibers subserve touch and vibration, and the small fibers subserve pain and temperature. And this is a problem at the moment, because in diabetics, they may have selective small fiber damage, and the large fibers initially may be okay. So you may have to sort of use slightly more sophisticated techniques, such as an electrode here, which has got, as it were, a water system and an electric current, and you can reverse the current and either heat or cool this electrode, and you can work out, and you ask the patient whether they can feel hot or cold, and you can see that the patient, we can start off at 32 and the patient can get up to 42 degrees and not feel heat. So you can devise a sort of a thermal threshold to detect thermal sensation, and that's important at the moment. Of course, by looking at the patient, you may see an autonomic neuropathy, lack of sweating, heel fissures, and also the dilated veins from arteriovenous shunting. The shunts between the arterioles and the veins basically are controlled by sympathetic nerves, and if they are deficient, the veins open up, and arteriovenous shunting can be the cause of that. So that's the way of picking up neuropathy. Obviously, the commonest complication is the neuropathic ulcer, classically on the plantar surface, initially surrounded by callus, and as Duncan has said, that callus should have been removed before it had developed this to this extent, and there had been breakdown underneath this. Not everything on the plantar surface is a neuropathic ulcer. So just beware. I mean, that was on the plantar surface. It really wasn't on a classical high pressure area. Should have been here, and it didn't really have the look of an ulcer, and that was a carcinoma, a squamous cell carcinoma, which had spread to the lymph glands and the groin already. So if something doesn't look quite right, refer to the dermatologists. But of course, the most common causes are trauma, and this brings me back to my underlying theme of vulnerability. This was a patient, there was a convection heater in the middle of the room, and he was decorating the room. And as he walked, as he was, as it were, decorating and wallpapering the room, and just sort of going by the convection heater, he developed these burns, and this gentleman put his foot into a vibrating foot spa and developed these neuropathy. So again, extreme vulnerability and susceptibility. The treatment, again, simply is the debridement and the offloading, which we'll come to. The debridement, again, to relieve mechanical forces. Again, removal of a callus. You would think, oh, is that just callus? This patient just came in routinely to the clinic, no problems, sits down, and the callus then is removed, and of course there's infection underneath and a large cavity which healed. And so the patient was completely unaware of that. So That's why the screening has to take place and why we need the susceptibility. That healed up very well. The blood supply was very good. And something we will come on to later in the course, obviously, treating those ulcers and preventing those ulcers. Relief of pressure is important. Total contact casts can be used, removable casts can be used, footwear can be used also. So that's the, as it were, the natural history in the neuropathic foot, the normal foot, the high-risk foot, going to the ulceration, important to prevent this because we then go to infection and necrosis. Now we can go down that route through a slight divergence, and that is going from the high-risk neuropathic foot to a Charcot foot, which then becomes ulcerated infection and necrosis. So for the last sort of quarter of an hour or so before coffee, I just wanted to talk about the other main complication of the neuropathic foot, and that's the Charcot foot, because the role of pressure relief and the assessment of mechanical forces is important in that. So this is the end stage Charcot foot with considerable deformity and swelling. 19-year-old girl just tripped over her dog about 8 weeks previously and then developed this severe deformity which led to ulceration and in fact, the hind foot was unstable. This was many, many years ago, and she had to have an amputation. So from that simple, just trauma of a trip, again the vulnerability leading to loss of leg. And this is a condition where you see diabetic foot vulnerability at its worst. A patient again who, this was in the 80s, tripped on the ice in round about King's, came into the casualty, slightly swollen foot, no questions asked about his diabetes or about his neuropathy, put into a tubey grip, sent on his way. And also the question was put, if it hurts, come back. Which medicine, that just doesn't apply to it if you've got neuropathy. It turns medicine completely upside down, as it were. Anyway, he did come back, and 6 weeks later, you can see, if I take you back, that's what the ankle joint should look like. The calcaneum, the talus, tibia, and the fibula there. And now, the talus has been virtually destroyed and there's been dislocation. Talus has gone forward, partly destroyed. So complete destruction. So again, we've got to have a very active approach to this. We've got to have early diagnosis, early intervention. And that is another theme which goes through diabetic foot care now, which Duncan has sort of has set the scene for. Early diagnosis, early intervention to prevent deformity. If we can't prevent deformity, we've got to accommodate deformity. And in some cases now, we can correct deformity. And one should diagnose a Charcot foot at this stage when the patient has a hot, red, swollen foot. So it's an inflamed foot. It's hot, red, and swollen. And you've got to have a high index of suspicion in a diabetic patient. A red, hot, swollen foot, one side, should be considered as a Charcot foot until proven otherwise. Now, the risk factors for a Charcot foot, you've got to have neuropathy, somatic, that means the sensation to pain and temperature may be diminished. Autonomic neuropathy, lack of sweating. In some cases, there is osteopenia, thin bones. If you're a nephropath, you're more susceptible. If you've had a renal transplant, partly because of the immunosuppression, I think. And paradoxically, the ischemic patient is protected. You need an intact circulation. You need a good blood supply for this usually to take place. And your diagnosis is really clinical on a hot red swollen foot. Now the catch is the x-ray may be normal, but you will have a positive bone scan and you will get MRI changes. So you will get a hot foot, you can measure the temperature difference between the other foot, and if it's greater than 2 degrees then that's significant. It's a slightly old picture, but this is a bone scan. You inject the patient with an isotope which goes preferentially to the bone where there are sites of repair going on. So this is, as it were, a hot spot here. So the isotope is rushing to this area, and that implies that there needs to be some repair. The osteoblasts are rushing to a site which has been damaged in some way. And you may think, that's good. Well, it is good, but the problem is that the response of the body to this initial damage is impaired, is deficient, is not controlled. There is, as it were, a hyper response, a massive inflammatory response. And why? Because they have neuropathy. Because we feel now that the nerves control this inflammatory response. So it's great that you get an inflammatory response, but what turns off the inflammatory response? Once you've healed you've twisted your ankle, and it's no longer twisted and healed. What turns it off? Well, it's the nervous system, and there is a deficiency here. So basically, a few case studies to show you. There is this patient who's got this swollen foot. It's hot. It doesn't look all that red, but it was red. The x-ray was normal. We couldn't see the damage on the x-ray, but we can see it on the bone scan. There's a great hot spot here. We put the patient into a total contact cast. There's a little bit of sclerosis, but the arch is preserved. The cast basically reduces the inflammation, reduces the damage that the inflammation can do to the bones and the ligaments. So the bones and the ligaments are damaged by this, and the arch is preserved. And that's the cast, and that's the no foot deformity. And this is another patient with a hot swollen foot, just to show how also we look at this. But we do the bone scan, and we can see that's the early phase. This is the 4R phase. And we can see there's a hot spot. So the osteoblasts are rushing in here. There's a blood flow phase here, early blood flow. So blood flow is an inflammation response, and the osteoblasts are rushing into this. So there's some mischief going on here. And how do we look at it in a more... The bone scan is great for telling you that there is something wrong. It doesn't give you much sort of anatomical information. So we use MRI. Now, just to highlight this, because you look at MRIs and perhaps you think, oh gosh, I'll never be able to interpret these. But basically, it's quite simple, really. The human body is just fat and water. That's all we are consisted of, fat and water. And fat and water have hydrogen atoms. Each hydrogen atom is a nucleus consisting of a proton, and this proton can resonate as a nuclear resonance signal. So basically, when you're put into the MRI, your protons are resonated according to certain magnetic fields that are applied, this magnetic pulse sequence. So the different sequences, so there's a T1 sequence, a stir, and a T1 postgadolinium. The details are not important, but basically, in the T1 sequence, you're getting the signal from protons that are resonating from the fat. So normal bone marrow is bright, it contains fat. Abnormal bone marrow is dark because the fat has been destroyed. With the stir, the signal is coming from the protons in water. So a normal bone marrow is dark. You're not getting a signal because there shouldn't be any water or edema there. Abnormal marrow is bright. And gadolinium is put in because it shows you areas of inflammation. Normal bone marrow is dark and fat is suppressed. So this was the picture of the patient that I just showed you with the bone scan, showing the hot area in the talonavicular area. Okay, so this is the talonavicular area. So you can see on the T1 it's dark. So the bone marrow hasn't got a proper fat signal, but the stir also has a signal. That means that there's water there, there's edema there, and there was some inflammation. So that's the normal calcaneum. Okay, normal bone marrow, good signal. And this is the usual signal, because there should be no water there. So there is inflammation going on here and edema. So the patient goes into a cast, and then 6 weeks later, you can see the talonavicular bones are better restored. There's good fat, there's a good response, and there's less water there. And when we did the scan at 6 weeks, we were able to see that there was, you can see that line along here, there was a fracture underneath the cartilage, a subchondral fracture, which was the mischief all along, which wasn't initially picked up. So this is between the talo and the navicular, this is a subchondral fracture. And that was the initial injury that patient had, which had produced that response. Now, if that patient hadn't gone into the cast, I think she would have developed the picture that I described to you earlier, and that poor girl who tripped and got that disruption. Because so we cut down the inflammation response. See, now, this is another patient. X-ray was normal at presentation. You can see the bone scan, marked activity, and when you do the MRI, you can actually see, in fact, a fracture there. There's a T1 fracture, there's a stir showing lots of edema, and the postgadolinium showing lots of inflammation. So the patient goes into a cast, and you've got to keep this cast going for some time, and at 4 months you can see repair of the fracture, less water here, and much less inflammation there. So we've controlled the inflammation, and the X-ray remains 7 months, and the MRI now at 8 months is normal. So that's the sort of what's going on. We've got to be aware of this, because there is a problem in diagnosis. People are not aware of this condition. And when we looked at 31 cases, 31 cases of patients who'd had a delay. What was the delay? What had patients? Well, 6 were thought to have had infection, 2 fluid retention, 3 no diagnosis was made, and 6 just a simple foot fracture. So 6 patients had had antibiotic treatment for quite a long time. So whilst the thought was of infection, they weren't casted. So casting was delayed for 15 weeks on average, and 5 weeks, and 1 patient didn't have any cast at all. The sort of classical orthopedic teaching that will only put a cast on you if it's painful is completely nonsense for the diabetic foot, as it were. For two patients, they were treated just with diuretics, with water tablets, and no diagnosis was made. I can see Duncan nodding. These are the misdiagnoses that happen for 1 year and 2 years. This is a problem with patient education. They didn't consider the swelling important. There was no pain, and they only presented when the foot had changed shape. So what had happened, they had had their initial trauma, they had developed their swollen foot, they'd carried on walking on it, they'd had their sort of inflammatory response, and after the primary insult, at some time with that inflammation, the ligaments went. And when the ligaments went, they got a deformity, and that's when they came, and that was too late. And then 3 patients, a fracture had been diagnosed, but they'd only been casted for a short amount of time. No X-ray when the cast was removed. Oh, it's not painful, we don't need to X-ray it. And then, the fracture was not healed, and when they got to King's, there was a Charcot Foot. So in 3, weight bearing was allowed despite evidence of foot fracture with no protection. 2 patients had delay in offloading, and 1 patient developed a foot deformity, but it had no offloading at all. So that's the delay in diagnosis. Infection 6, foot fracture, fluid retention, and no diagnosis. Just for your information, mechanical aspects will be talked about. Is there a biochemical aspect? Well, Bisphosphonates and calcitonin have been used. There has been a study with bisphosphonates, a single infusion of permethrin. Bisphosphonates reduce the activity of the osteoclasts, which, as it were, destroy bone. And one theory is that the osteoclasts are overactivated in this inflammatory milieu, and they, as it were, damage these bones. So if you put in, as it were, an inhibitor of osteoclast absorption, will this help? Foot temperatures and symptoms were measured. And also there was an alendronate study, 20 consecutive patients. That's another osteoclast inhibitor, 11 patients in the active group, 9 patients in the control group. The message from both of them was there was a reduction. Sometimes the Charcots can be a little bit painful, and there was a reduction in painful symptoms. There was a reduction in bone turnover, but no significant difference in reduction of skin temperature. So really, it was from clinical point of view, it was a negative study, and there's been as it were, a study of patients reporting of what happened through the internet in Britain, and association between treatment outcome and the bisphosphonates. And you can actually see that, so that's people who got bisphosphonates, the dark light did not get bisphosphonates. And you can actually see in this study, I know it's an internet study with people, as it were, reporting over the internet, the actual duration of treatment, of casting, was actually higher with the people who got bisphosphonates rose than didn't. So there's a question mark really on bisphosphonates at the moment. Calcitonin is another active inhibitor of osteoclasts, and Jakowska in Prague works on that. 28 patients, 15 in the active group with calcitonin, 13 in the control group. Again, a reduction in bone turnover when you measure the bone turnover markers, but no significant difference of the reduction in skin temperature in the actual foot. So just to finish, the great emphasis is on everyone who's got contact with the diabetic patient, and that's yourselves and anyone diagnosing these Charcots earlier with a hot, swollen foot to get the inflammatory response down before it wreaks havoc. If in the later stages, when you've got Charcot deformity, there is another, obviously, approach, and that is important for orthoses and for surgery. If the deformity is stable, we can accommodate it. If it's unstable, we can correct the deformity. So we've got here a bilateral Charcot feet. Deformity was stable, and this patient had a Charcot restraint orthotic walker, custom-made orthosis which controls limb edema and returns the patient to walking, and followed up by an AFO and a specially made cast. But Willie Monroe will go more into that. If there's an unstable Charcot deformity, then we can go into correcting that deformity either internally with operation, or externally with a special frame and a gradual correction of the deformity. But these are complex patients, and these procedures do have complications. So we've got a patient who's got a Charcot, he's got a deformity of the midfoot, and also now he's got an inversion. You see, he basically had a lot of sepsis on that lateral aspect, and his peroneus went, and he inverted. And so and that's his foot deformed. He had internal stabilization with an intramedullary rod and nails, which returned him to a pretty good plantar-grade foot. And these are now really quite successful operations. There's another patient who we weren't controlling with a total contact cast. She again had a deformed inverted foot with a plantar ulceration, because this is the extent of the deformity. So this is a talar spatial frame that gets put on and pins get put through. It's a very complicated procedure which the orthopods control. There's a computer program where you can adjust the tension in these wires and adjust the position of the wires to gradually release the pressure on the soft tissues. So there's, as it were, a straightening, as it were, from soft tissue point of view of the foot compared with the leg here. And then she followed up with an intramedullary nail, and to return to a pretty good plantigrade foot in that patient. But she got further complications with some fracture in the calcaneum, but that has been now dealt with. But just to finish, and just to come back to this great picture of vulnerability, these patients, they get into trouble, whatever you do to them. And of course, what is the trouble here? They've got the pins here, and they get infection. And that's the infection with that pins. Diagnose it early enough and you can treat it. We thought that was a fairly explicable complication. But then over and above that, they get trauma to their frames, and you can see that is completely fractured from that metal there, that rod. So I think the patient, you can imagine the physical forces on the patient with neuropathy. I mean, we haven't talked about this. Massive physical forces, uncontrolled physical forces in walking, which we need to control with footwear and shoes and lead to ulcers. But even when you put a metal frame on them, they manage to break the metal frame. That is a completely fractured rod. You see, that should be completely, that's a discontinuity there. That's been completely fractured. So I think that probably should, going back to the Charcot, I've stressed it because we've got to recognize the early symptoms and institute appropriate early intervention and successful management. But I think it does show how vulnerable our patients are from the neuropathy and the Charcot. So it's coming up to 10:02 now. I think I'll finish then. We'll break for coffee and then go on to later. Thank you very much. Thank you. Please feel free to interrupt as we go along, okay? So the second session, I'm going to talk about infection and ischemia. And these are the two factors particularly which lead to destruction of the feet. Now, you may say in your practice, well, that doesn't really totally involve me. The ischemias for the vascular surgeons, the ischemia for infectious disease and antibiotics. But the main point I want to make is that it's early diagnosis which is the crucial factor. And for that, who makes the early diagnosis? It's the patient or their carer or their attendant. You know, it may be the carer in a nursing home, and that may be the crucial factor. You know, if they diagnose an infection at day 1 instead of day 5, that could make the difference between 6 weeks of admission or 1 week of admission, or dare I say it, it could make the difference between life and death, actually. So I think we all have to, if we are aware of diabetic patients, we need to understand infection and ischemia. So I'm just going to go with the principles of management. And I think there's misunderstandings in diagnosis and treatment. And there are lots of controversies regarding infection, which is, sorry, I'm going wrong. Okay, now I think there are 10 myths which are linked to diagnosis and treatment of diabetic foot infections. And this, I think, goes against early diagnosis and early intervention. Sorry, I'm just wondering whether I'm going backwards or forwards, actually. I'm pressing, yeah, okay, fine. There we are, okay. Myth 1. Diabetic foot infections always present with classical signs of local infection. Wrong. Often erythema and pain may be absent. And why is it absent? Again, because the patient have neuropathy. I'm sorry to keep going on over this, but they've lost their very small, what we call C fibers, which subserve pain and temperature, and they have a reduced what we call axon reflex, which is a reflex which tries to dilate in response to this, and there's a failure of vasodilatation. Now you may think he's getting a bit confused here, because I just told you with the Charcot there's a massive vasodilatation, and here I'm now telling you there's a failure of vasodilatation. Well, I think the Charcot patient has a specific neuropathy that allows vasodilatation, because compared with the number of ulcers and the number of Charcots, the Charcots is much reduced. So these patients are a class apart, and I think they have a very, very specific neuropathy which the other patients don't have, which allows this vasodilatation. In general, there is a poor vasodilatation. Now, if the patient is ischemic per se, that is, the blood vessels are blocked, then they have impaired maximal blood flow. And of course, I have to stress again, they have immunopathy, that is, their immune system does not work. Their white cells cannot kill bacteria very well, and they cannot form abscesses very well as such. So diabetic foot patients are always present with infections. 2, diabetic foot infections always present with classical signs of systemic infection. Wrong. Often there is no leukocytosis and fever. That is, when we get an infection, evolution has given us a protection. We put up our white count because we need all the white cells to rush in and phagocytose the bacteria and kill them, and we need a fever. We need the temperature to go up because that also helps us to get rid of the bacteria, as it were. And the poor diabetic patient does not do either. And leukocytosis is a poor indicator of acute osteomyelitis. 54% of patients with acute osteomyelitis have a normal white cell count, and often there is no fever. And why is this? Neuropathy. What's the mechanism for putting up our temperature? Our hypothalamus resets our temperature. But the hypothalamus has got to get a message here that something is wrong in the body. So if you can have a massive infection in your foot and the brain doesn't know about it because it's not getting the signals from the nerves, it doesn't do anything about it. Okay, I know some of it's blood-borne, so some of the cytokines come via the blood, so that's not the whole picture, but I'm sort of oversimplifying it to make a nice story, really, in that sense. But it's certainly, and this is a practical point. You cannot take a patient's temperature and see it is normal and be reassured that there is no problem. It does not apply in diabetes. Second, and even a small rise in temperature, and we see this on the wards often. Oh, the houseman will say it's only 37.5, but it's any temperature rise in a diabetic is significant. And secondly, the white count. Now, why do we, the white cells, they have a half-life of about 10 hours in the blood, and they're usually about 6 to 10,000. But when we get an infection, we get a high white count, so the white cells are raised, they come to kill the bacteria, but where do they come from? How do they suddenly rise? Well, they come from the bone marrow. The bone marrow has got to, as it were, pump these white cells out. And the bone marrow has a nerve supply. And that nerve supply is damaged in diabetic neuropathy. So that system is deranged. So they have what we call a double whammy. No fever, no white cell count. So diabetic foot patient, absence of systemic signs, fever is often absent. 18 patients had a mean temperature 37.2. Only 4 patients had a temperature of 37.5. So we've got to look for very subtle early signs of infection. The base of the ulcer changes from pink to yellow, increased friability of granulation tissue, and increased amount of exudate. We've got to look for those signs. Myth 3, digital necrosis is due to a blockage of the microcirculation. Wrong. Digital necrosis is caused by infection, and this is the classical I just suddenly realised why. You may think I'm going dyslexic. It's upside down. So that's the reason why I've been. That I couldn't work it out. Actually, that's right. I suddenly thought it was gone the other way. I was going to the left instead of to the right, not politically, as it were. So anyway, this is diabetic gangrene, and we've got this classical toe, and then we've got this black toe, the gangrene of diabetes. And what is this due to? Well, this is due to basically a septic thrombosis. You see, this is the digital artery. Okay, there's some intimal hyperplasia there, but there's a septic thrombus there which has blocked the artery. And if both arteries go, then one gets necrosis. And secondly, this is another picture showing septic arteritis, medial calcification and intimal hyperplasia. That's the original lumen, and you can see it being encroached by this septic thrombus. So that's a thrombus caused by infection. And as Duncan mentioned this morning, infection is preventable, and this septic thrombus is theoretically, as it were, preventable. This is some blockage, this is some narrowing of the artery due to the hyperplasia of the intima, and that's related to the diabetes, and that, in a sense, is not preventable. But say a week before this happened, this patient did have a lumen which was pretty respectable. Now he's got an ulcer, now he's got infection, he's got an infective thrombus threatening to block that vessel, and that is that is preventable. And this is a patient who presented in the community. She was a patient who had some degree of ischemia and had been treated with a balloon angioplasty, and no more could be done. And the district nurse visited this patient, and he reported that the toe was blue and painful. And she could have thought, well, this is ischemia, he's had his angioplasty, he can't have any more thing done. But she noticed that there was some discharge here and was concerned. And there she was in the home, badly lit home, Friday afternoon, 2 o'clock. What does she do? Well, she sent him in to us because she was worried that there was significant infection there. And we agreed that there was some discharge there. We thought this could be infected on top of an ischemia. So we admitted the patient, gave him antibiotics, and by the Monday, that was all pink. So the infection was taking oxygen away from the skin, as it were, and compromising it, and as it were, leading to a relative ischemia. Now, if she hadn't have done that, I think that toe would have been black by the Monday. So, and that, I think, reflects Duncan's epithet right at the beginning, that you've got to get it right with these patients. And if you get it right, it's very rewarding. If you get it wrong, it can be very frustrating. Okay, myth 4. Now this is where we get slightly controversial. Diabetic foot infections are caused only by gram-positive bacteria and anaerobes. As you know, with bacteria, they can be gram-positives, they can be gram-negatives, and they can be anaerobes. And there's a bit of controversy in the diabetic world. You know, what are the real nasty bacteria? And there's a feeling sometimes that the gram-negatives are not all that important, but there is a unique microbiology. Gram-positive, gram-negative, and anaerobes occur, and that's why. And that's why it's difficult to treat foot infections sometimes, because you don't know what you're dealing with. You can have Staphylococcus aureus, that's the most common one, but you can have what we call these anaerobes. These are bacteria that thrive without oxygen, so they're often deep in the tissue. And then there's the Streptococcus, and then there's the gram-negatives, the Proteus, the Pseudomonas, the E. coli, and the Klebsiella. Normally, those are all found in the gut. They are gut organisms. But in our diabetic patients, they find themselves down in the ulcers. So they migrate from the gut down into their ulcers. And this is, I think this is we were talking about our various roles. This is sort of the main role, I think, of apart from the diabetologist, who by sort of inherent helps to control the blood glucose, tries to treat the infection, because they are really quite complicated infections, because you don't often get one organism per se. And even when you get black toes, you get the same array of organisms: staph, strep, anaerobes, enterobacter, proteus, and Klebsiella. So you've really got to have a very concentrated, intensive approach to infection. Tissue specimens, deep wound swabs, urgent micro, talking to the microbiologist who will be looking at the plates on the rounder. We used to be able to go up and look at the rounds, but now we have to sort of talk to the microbiologist, intravenous antibiotics, and daily inspection of the wounds. Now these last 5 are not quite so important. I'll go over them. Diabetic foot infections do not always need investigation with wound swabs and tissue samples. We believe they do, because you've really got to try and find the organism with tissue samples so that you can plan rational antibiotic therapy as such. So now this is a slightly odd case, but this patient was fine when he left us, and then he went off to America for a holiday in Florida. And within about 3 days, he was in the emergency room with a very low blood pressure, and his feet were like this. And to cut a long story short, he had an infection with this Vibrio vulnificus, and what he had done was, once he got to Florida, he had eaten raw oysters. Now, raw oysters taken from the Bay of Florida should be cooked. If you eat them raw, they may be culturing this organism called Vibrio vulnificus, which the locals call the monster from the deep. And you can, looking at those legs, you can understand why. And basically, that had got into his system, got into his bloodstream, and then got into the skin. So it was it wasn't a local infection; it was like a metastatic infection, and had caused these organisms. Now, everybody eating raw oysters in Florida are not getting these legs. And who are getting them? It's the diabetic patients. It's the lymphoma patients, it's the HIV patients, the patients who are immunocompromised. He did well. It's a very susceptible organism to antibiotics, and he had skin grafting and did very well. So, I mean, that's picking up a specific organism. I mean, we're not seeing this every day at King's, or that organism, but it's interesting to pick up the right organism. So when a patient comes to the clinic, with microbiology, you take a swab, but you don't get the result for a couple of days. So you've got to guess the organism. We'll give empirical antibiotics. So there's a query of whether you should cover gram-positives or anaerobes, or cover gram-negatives as well. Just to point out that virtually any organism can cause mischief in the diabetic foot patient. And this is another organism called Pseudomonas, and that was responsible for this infection leading to necrosis. And this patient was getting flicks of temperature on the temperature chart. Here, you see, he was getting flicks, but it didn't really settle until we gave a specific agent which attacked those Pseudomonas organisms, and that helped him to recover. So any organism, again, susceptibility. It's just not one or two organisms, and that's what makes diabetic foot infections quite difficult to treat. You know, if you've got a pneumonia, it's normally one or two organisms. If you have a meningitis, it's just, well, 2 or 3 organisms. But in a foot, it can be various organisms. But once you've got the organism, then you can, as it were, focus the antibiotics, and you can go from your in the follow-up treatment, broad spectrum should be given wrong. No, because you get the organism. So, for example, with this patient who needed debriding, that goes to the lab. We picked up a Staph aureus, Citrobacter, and mixed anaerobes, so 3 organisms, and this was now about 5 years ago. We treated with a specific agents. Now in interests of antibiotic stewardship, we would treat with one antibiotic, which we would try and cover cover those organisms. From the point of view of antibiotics, there are various different regimes, but different sensitivities locally. So that's the international consensus website where you can look at the various different antibiotics. Myth 8, diabetic foot infections can be treated with antibiotics alone and rarely need surgery. This is not true. The diabetic foot often needs surgery, and it may be podiatric surgery at the bedside, and it may be surgery in the operating theatre to remove sloughy, liquefied and necrotic material. And so what are the indications for surgery? A large amount of sloughy tissue, localized pus, where it's becoming bluish or purplish, or where there is gas in the soft tissues. So, I mean, this patient was sent up to us as a case of gout. But it was obviously not gout. I think the doctor might have thought there was sort of some gouty tophus there. But it was an ulcer. And you can see that there's a lot of sloughy tissue there. And that needed debridement. And all that tissue was removed. But he had a good blood supply and he heals up very quickly. And this was a patient who trod on a piece of glass. And you can see there's an infection complicating that. The glass was out, but there were beads of pus coming there, and this patient needed a debridement and healed up very quickly. So, you know, again, it's within the framework that Duncan painted of a patient who's in trouble, getting to a multidisciplinary clinic where they can make the right diagnosis and then put the patient down the right treatment pathway. Osteomyelitis must always be treated with surgery. This is very, very controversial. Modern antibiotics with good bone penetration may cure osteomyelitis. Well, again, that is controversial. But it's the sort of patient we see here where they've got an ulcer. There again, it's not plantar, it's on the margin. The patient had ischemia. This is an angiogram, and we'll come on to this in a few minutes. So this is an artery coming down behind the knee, and it breaks into three. The anterior tibial, there's initially a trunk, and then there's the perineal and the posterior tibial. And you can see on that side it's pretty good. On this side, the anterior tibial is not very well seen because the dye can't get through because it's blocked. That patient then had an angioplasty, a balloon angioplasty to improve the circulation there, and that can in fact improve the flow down the artery into the leg. The patient had underlying bone involvement. In fact, had really had fragmentation and almost a fracture there underneath that ulcer. Well, the ulcer was here, then that was a fragment there. So should that patient have the toe off because that bone was involved? Well, we picked up the right organisms, treated them aggressively, and the ulcer gradually healed, and the fracture healed, and the bone reformed. So in that sense, and there's full healing. We find if the soft tissue repairs itself, then the bone will repair itself. And nowadays we do have antibiotics with really good bone penetration, fusidin, clindamycin, rifampicin and Cipro, and these complement any possible surgery. I think I don't want to leave you with confusion. The reality of it is, I think in most of our patients, and Duncan perhaps would agree or disagree, we do treat with antibiotics, but the podiatrists will, as it were, remove any bone that is easily available, any sequestrums. So they have that sort of, as it were, podiatric surgery. They have the antibiotics, and that usually is successful in the majority of cases. And finally, amputations from diabetic foot infections are inevitable. Wrong. Early aggressive empirical treatment can save toes and limbs. So we've got a toe here with marked cellulitis, and also here down to bone, involving the bone. And you can see here fragmentation, as it were, and osteomyelitis. Now, this is the controversy. Some people would say that toe should be removed. And there's a good argument for that. In this circumstance, for various reasons, the toe was not removed. The antibiotics were continued, targeted antibiotics, and the toe healed. And interestingly, although there was some ankylosis, the bone actually healed. But that took a little while for antibiotics to be used. And I'm not sort of putting this as a sort of a clever case that we can heal osteomyelitis without surgery. I'm just putting it as a possibility that antibiotics can now achieve major results. But we have to be careful of our use of long-term antibiotics. So that's the sort of the general approach to infection. But your role and all of our roles are basically early diagnosis of infection. When we're looking at a patient and looking at the case for their shoes, if they've got a hot swollen foot and the ulcer looks infected, then it's up to anyone in contact with that patient to make that diagnosis and to make the appropriate therapeutic steps. Now, finally, we have the neuroischemic foot ulcer, and now we're going on to the patient who's got both neuropathy and ischemia as such. And of course, there the approach is to deal with the ischemia by revascularization, and we can do that by angioplasty or bypass. The patients need also debridement, clinic or operative debridement, and they also need off-loading. So again, this is the picture of angioplasty. It's very interesting. In diabetic patients, it's the arteries below the knee which become infected, involved with the narrowing, and you can see this is the popliteal artery, and again the anterior tibial is not showing up because of blockage, and there's some narrowing here in the tibioperineal, and after a balloon you've got some slight widening here, but you can actually see the anterior tibial. Where this is not possible to dilate these, then the patients have a bypass. So a vein is taken from the blockage here and put usually onto the dorsalis pedis artery, which sometimes can be found and is not so heavily involved as the arteries in the calf. And here again, the emphasis is on urgency, as it were. So we have a diabetic vascular one-stop clinic, patients treated at the earliest stage of disease, within 7 days of referral if ischemic, within 24 hours if urgent, if there's necrosis, if there's infection. They will then go to our vascular lab and the clinic assessment in the same day. We will have what we call duplex angiography with Doppler to locate the arterial disease, and then referred for angioplasty. And that's through our vascular surgeon. So these are patients now, and as Duncan has said, these are the most common patients coming to our clinic. 312 with ischemia, 250 were regarded suitable for angioplasty. We can do a lot of them as day case procedures, 194 at inpatient procedures, 55 patients suitable for bypass, 40 as infragenicular below the knee, and 7 above the knee. So distal bypass or angioplasty is a very active treatment. Debridement of these patients is also very, very important. They get this dry necrosis, which is dealt with very skillfully by the podiatrists to remove that area, and often one can get healing of these toes. But it's very, and this is a sort of neglected, I think, field really. The shoes and the footwear have been concentrated on the neuropathic foot, but also these feet. These neuroischemic feet need very, very much protection. It's not protection on the plantar aspects. The plantar aspects are usually not affected in the neuroischemic foot, but it's the margins the medial and the lateral aspect and the tips of the toes, which need protection. Of course, there are other forms of debridement. This patient had had a bypass. There was still, and an operative debridement, there was still some areas of necrosis. And this patient had what we call a vac pump, that's vacuum-assisted closure. So they have a special foam dressing and then attached to a pump which exerts a vacuum which takes away all the exudate from this wound continuously. And that's after 2 weeks of VAC therapy. That's after 4 weeks. You can see the granulation tissue, 6 weeks, 8 weeks. And you can see, then of course we went to conventional dressings and the patient did well. This is a patient who she came to us very late. This was an area of necrosis and infection. You can see it there, and this is the progression of the neuroischemic foot, and this should have been diagnosed probably a week before and brought to the clinic, but it wasn't, and the patient essentially had to have an amputation of the forefoot, had a bypass, and had this then wound. This is sort of through the midfoot, basically, and you can see a wound swab being quite deep in there. But then this patient had VAC therapy. You can see there's still quite a lot of fatty tissue there which needed debridement. 4 weeks, 5 weeks, 8 weeks. VAC was stopped at this stage, but then it went to heal. And these are patients, she had ischemia, she had a bypass, she was a renal patient as well, which are very difficult to heal, but nevertheless important. And those are our friends, which Duncan mentioned. That's another process of healing the maggots, which go on to the foot to achieve some healing. We don't use them a lot, but we're very impressed. They're much more impressive than surgeons. You can put them to work on a Friday afternoon. They'll work all weekend. They don't have to be paid. They don't have to be fed. And then you come in on Monday, and then you just syringe them away and get rid of them, and they've done a good job. That's used on some necrotic wounds. And finally, you may say at last, these neuroischemic patients also need proper footwear. Sometimes they need special boots made to protect the margins. This is a Scotch cast boot when there may be large ulceration, but it may be just a well chosen shoe with a wide toe box, a lot of space here to protect the margins. And these, I think, need to be used both preventatively and actively in protecting the neuroischemic foot. So I think I basically will conclude by saying that this is the natural history which we have to conquer. I think for the rest of the time we're going to really concentrate on this area and this area. I have necessity alluded to this, partly I think to alert you to the problems of failure to deal with at this stage, but also the fact that when you are looking at feet and you're looking for footwear, you may see patients at this level and you've got to actually act aggressively. But it's a multidisciplinary approach with the wound, mechanical, which we're going to concentrate on, the vascular, the microbiological, metabolic, and educational. And these are all pieces of the puzzle, as Duncan has said, and you've got to get them all right. There hasn't got to be a weak link in any of these there. And it needs a team approach. And that's some of our team, and it's our podiatrists and our nurses and receptionists and research fellows and surgeons I wish to apologise for our vascular surgeon who's making, he tells me that that's a sort of a gesture of welcome in his world, as it were. You can keep down the number of amputations. You can't actually completely rule them out, but overall you can reduce the amputations. And in that, it is hard work, but nevertheless, it's, as Duncan said, it's very satisfying. So I'm going to finish there, thank you very much, and just loads a little more questions before we go on to the mechanical aspects. Thank you.